Good afternoon, everyone. Sorry for starting a few minutes late. I'm Councillor Jo Coles, and I am the Executive Member for Health and Wellbeing and Adult Social Care, and I'm the Chair. I just wanted to say a couple of things before we start, because there were a couple of operational issues last week that may both have been confusing for participants and may also have affected attendance. So huge apologies if that has been the case, or if that confused your diary as much as it did mine. So there were some operational issues that meant that we had to explore moving the meeting to a different date. The logistical difficulties in doing that meant that we decided that it was much better to revert to the date that had been originally planned. And that meant that the agenda for the meeting was not published within the statutory timeline, which was 5 working days before the meeting. That means that officially today, the meeting cannot make any formal decisions. As Chair, I consulted with the lead officer and determined that that probably wouldn't affect our business, because most of the important business that we are talking about today is a discussion, an advisory context. So therefore, if there are any items that end up requiring a decision, we will have to defer them to the next meeting, which will have been given the 5 working days notice. I also just wanted to let people know that we have slightly changed the agenda around in case you looked at an earlier agenda. So items 7 and 8 have been reversed. So we will do the presentation on adult social care CQC readiness as item 7 and the Healthwatch report as item 8. I'm hoping to try and keep us to time, and I'm anticipating quite a lot of discussion on some of these items, so I'm keen to press on if that's okay with everyone. If there's time, I will try and take a very short break at around 5:15, 5:30 if that's possible. But if we're running, because we started a bit late, that may not be possible today, so I'll do my best. Are there any agenda item 1 is any declarations of interest? Thank you. There are no declarations of interest. Oh, I see. I'm not doing the minutes because we're not doing anything formal. I see. I can't even approve the minutes of the last meeting in this meeting, because I can't sign them officially. All right, well, we'll do double at the next one. The second item on the agenda, therefore, is public participation. And thank you, everyone who's come along today, either to speak or to support someone who is speaking. I have got everybody here, and I understand the last person on the list has sent a written statement, which I will, if it's okay with everyone, read out at the end. The first public participant is Manar Manusiak. If you'd like to come forward, hi, thank you for coming. Do they have three? Yeah, you have 3 minutes. Would you like me to give you a warning when you've got 60 seconds remaining, or shall I just tell you when your 3 minutes are up? Great. Okay, the floor is yours. Thank you. If you just press the microphone to speak.
Thank you, Chair. I'm speaking on behalf of Living Autism's autistic and neurodivergent clients in York and North Yorkshire. I'd like to start with something positive. Some of you will remember when York launched its all-age autism strategy in 2017, a progressive strategy focusing on both children and adults. With the launch, task and finish groups were set up. Living Autism was honored to be part of the Inclusive Communities group and to collaborate with the council to roll out autism awareness training to people from over 60 organizations in the city. York was not only talking about becoming autism inclusive, it was actively working towards it and leading the way in the country. Now to today. It's disappointing to see York has gone back 15 years to the days before the Autism Act 2009, after which the government published guidance and further legislation. Most recently, the National Strategy for Autistic Children, Young People and Adults, 2021 to 2026, and the Health and Care Act 2022. York's all-age strategy ran out in 2021, and there's been no new strategy. The legislation and strategies emphasize the importance of early and timely diagnosis for the pathway to support, so crisis situations are avoided or reduced. Crisis situations that are costly in human lives and put severe pressure on resources and services. When people contact us at Living Autism, we guide them on the referral process. We're honest about the long waiting lists and recommend services where possible for support whilst waiting. We know how difficult it is to wait a few years, but there's hope because they know the assessment will come eventually. In York, we can't give people that hope anymore. The screening criteria mean a person must be in extreme crisis before they're referred for an assessment. Such crisis that neurodivergent people might not be able to visit A&E or pick up the phone and ask for help or complete an online form. Last week, the government published its suicide prevention strategy, and autistic people are specifically named as a vulnerable group to be supported. 5 times as many autistic adults commit suicide as in the general population. What would the figures be for those who are not yet diagnosed and have no hope of getting an assessment? What do we tell our York and North Yorkshire clients who ring us in distress because their family relationships are breaking down, they're losing their jobs, they're losing their homes? They need to know if they're autistic or ADHD to get the right support, and we all need that knowledge as early as possible before crisis hits. Please stop this particular screening tool that takes away hope and let York become progressive again instead of regressive. Thank you.
Thank you very much indeed. Yes, thank you. That's great. And thank you for your comments, which we will discuss when we reach the Healthwatch report on the agenda. Helen Jones is my next speaker, if you'd like to come forward. Thank you, Helen. I understand you're also speaking on the Healthwatch report.
Yes.
Yes, you have 3 minutes. Would you like me to give you a 60-second warning when you're near the end, or are you happy for me to just tell you when 3 minutes are up?
A warning, I think.
Okay.
I am the chair of York Disability Rights Forum, and we've been engaging with people affected by the autism and ADHD pilot since it began, including working with Healthwatch to create the evaluation report that was on the agenda today. It's significant that none of the challenges or questions about risk, consultation, or data protection have changed the irresponsible decision to extend the pilot. Today, we want others to recognise that those seeking autism and ADHD assessments are simply the group currently being targeted for financial savings. Autism and ADHD are marred by myths, misinformed opinions, and explicit questioning of the validity of our identities, making us an easy target, low-hanging fruit to cut out of NHS budgets. We and the ICB know that this decision saves no money overall. More demand gets put on the mental health system, more people are hospitalised, and more people die. When looking at papers for this meeting, we noted that as a result of dementia referrals far exceeding pre-pandemic levels, the response was to secure funding for additional training in dementia diagnosis to help increase capacity and reduce waiting times for assessment. This raises the question, why was this not the process to deal with the waiting list for autism and ADHD assessments? Why was our access to assessment reduced instead of facilitated? It would appear that the ICB is biased against our community, and this is evident in their actions, the pilot, and the reports. They've already shown that our patient voice means nothing. We have managed to fund a legal letter, but it's out of the reach for so many. It's yet to see what the impact of that will be, but it cannot be the expected level of response for issues in the future. How then are we to hold decision makers to account for their actions? We are told the ICB monitors itself, and there's no one to help us when they harm us. Help us find a realistic answer to this question. Today, I would like each of you to consider if the next group the ICB refuses to assess, diagnose, or treat includes you, your friends, or family, how might you reflect on the discussions that you're going to have today? We ask, do you want a system where decision makers are held accountable for actions that cause harm or not?
Thank you very much, Helen, for your comments. which I should have said, Jamila Hussain, the Director of Adult Social Care, is in the meeting remotely. I should have said that at the beginning, apologies. So she will also have heard those comments. Our next speaker is Hazel Kerrison, who is also speaking to the meeting about the Healthwatch York report. Hazel, would you like me to give you a warning when you've got 60 seconds left? Okay, thank you. Yeah, no, that's why I'm asking.
As a neurodivergent person diagnosed both autistic and ADHD, who also has a history of self-harm and suicide attempts, I feel it's very important to highlight the vulnerability of those affected by this pilot and the implications of its definition of risk. One of the criteria of assessment under this pilot is that if a person is deemed at risk and has not only undergone a mental health assessment, but also has a crisis plan in place. I'm not sure how many people outside the system are aware of how and when crisis plans are put in place, but as a few examples, I myself had experienced multiple psychotic episodes and hospital stays before I was given a crisis plan. It can also be seen from the inquest carried out after the death of Zoe Zaramba, I'm sorry if I said that wrong, that at the time of her death, she had no crisis plan. I could go on and give more examples of people who've been very ill and even died and yet had no crisis plan in place, but I've got other points to make in limited time. There's a valid question on how we're defining self-harm within this context. This is a question I've asked the commissioners multiple times and gotten no answer. Unlike self-injury, self-harm has not got any definition within the DSM and tends to be incorrectly used to mean self-injury or as an umbrella term. As I've been refused clarity on this issue, I am forced to assume that what they're defining it as is danger of suicide or self-injury. And as such, we're missing many vulnerable people whose risks fall outside this very narrow definition. Both autistic and ADHD individuals are at great risk of being exploited by others, risk of eating disorders, substance misuse, financial issues, employment difficulties, and many other vulnerabilities. Even within the realms of self-injury, the reliance on a paper trail misses a high proportion of individuals whose method of choice may not necessitate medical intervention, or those like myself who found other means of having injuries treated without a visit to A&E, which as a neurodivergent person is both sensory and social hell, not to mention all of the issues raised by the Breaking Point report. As I explained last month, there's a woeful lack of specialist services for and understanding of neurodivergence, and this includes within the mental health service. Many people experience misdiagnosis, incorrect treatments, and a failure of their needs being met. A lot of autistic and ADHD individuals find this not only invalidating, but also traumatizing. What people need is accurate assessment, accurate diagnosis, accurate support, not to be forced to engage with a system that is not designed for them because there's no other way to gain an assessment. I'm going to leave you with a quote from the government strategy on suicide prevention that was published recently. Undiagnosed or late diagnosed autism may be a preventable risk factor for suicide, and therefore early identification and timely access to autism assistance services is vital. This also goes for ADHD, adding that bit myself. Thank you very much.
Thank you very much, Hazel. Our final speaker in person is Gemma Barstow. If you'd like to come forward. Would you like me to give you a warning when you've got 60 seconds left?
No, because I think I'll panic then and forget what I'm saying.
I'll just tell you when you're up, your time is up then. Thank you.
Okay. Due to lengthy waiting lists nationwide, the government agreed
that accessing disabled students allowance could also be done through being placed on a waiting list by a GP. Access to a waiting list is possible for students in any other part of the country, to my knowledge, other than right here, where we are, for whatever reason, absolutely preventing our youth from accessing this vital support that will enable them to complete their university degrees. This is hugely detrimental to York as a city if we think about the impact of the students returning home from university, having achieved absolutely nothing other than the trauma of being forced to drop out because they're unsupported. This will naturally have a knock-on effect on the local economy, as many of them may not be in a position to then begin work. These people will become significantly and potentially long-term underemployed, which is already a risk for many autistic and ADHD people. But why just concentrate on students who already live in York and move away to go to university? Because additionally, what typically happens in our many years' experience in higher education is that students choose to come to York to study at one of two major universities, and within the first few months recognise that they're struggling. The reason they are struggling is because they have been masking or going under the radar for years as undiagnosed autistic or ADHD. However, the unstructured nature of university, combined with the need for independent learning and motivation, means that many may start to struggle. And it becomes apparent that they have not been diagnosed at this point. So these students then historically have been referred to a local GP in York, because all students register when they start university. However, not only are we now disadvantaging local York students who live here, we are also disadvantaging students who move to York to come and be at university here, shoring up our local economy and funding the universities within this city.
Thank you very much, Gemma. The final public participant has sent a written statement, which I've got here, and I'm going to just read out for the board. So the statement is from Catherine Owens, and it is also on agenda item 8, sorry, it was 7, on the Healthwatch report. So this is from Catherine Owens. I'm a neurodivergent person and have worked on accessibility issues throughout my career. Thank you for reading my contribution with reference to the Healthwatch report. The chair began the last meeting by stating her intention to focus on reducing health inequalities. Addressing the barriers to ADHD and autism assessment as raised by the report provides the ideal opportunity for her to translate words into deeds. I urge you all to consider the collective responsibility of the board for system redesign as directed by the Better Care Fund guidance. The simplification of points of access and care pathways are key priorities, yet the report in question shows the redesigned pathway to have become more complex and less accessible. It sets out issues with process and information, which are significant because variation in health literacy plays a powerful role in health inequality. In England, 43% of adults do not have the literacy skills to routinely understand health information, rising to 61% for numeracy. Yet York's confusing, poorly explained pilot, to quote the report, fails to have regard for the accessible information standard that people must be given information in a way that they can understand. The pathway is only available online and requires a high level of literacy, IT skills, and digital access. People have been left bewildered by the do-it profiler. Even health professionals don't understand it. On one level, the statistics shared by Healthwatch are useful. For example, more than a third of our respondents reported that the do-it profiler was either difficult or very difficult to complete, but they only cover people who A, were able to engage in the pilot process in the first place, and B, went on to feed back to Healthwatch. So the full picture will be significantly worse than the reported situation. Even those who completed the online process are left without clarity. The report included comments such as, I didn't get a single piece of feedback to say whether I was even being considered. Although this board doesn't directly commission this kind of pathway, it is expected to sign off combined budgets and must have oversight. I'd like to remind you that mental health and autism continues to be an integral area of the Better Care Fund on an equal footing to physical health. The objectives apply to all settings and contexts, including preventative support. The Healthwatch report highlights multiple barriers that must be broken down in order to meet these objectives and the needs of the community. This is your opportunity to do so. Thank you, Catherine, for sending that in and to everyone who has taken part in the public participation session. All the contributions are incredibly welcome, and all will be considered when we are discussing that item on the agenda. I will move on to the next item on the agenda, which is item 3, which is the chair's briefing. Everyone should have had a copy of that in advance. I just wanted to draw people's attention to the local updates section of the report, particularly around the core commitment in the new council plan, which was approved by the executive last week, and which includes a core commitment around health and ensuring that health is at the heart of the decision-making of the council. The other commitments being around equalities, affordability and climate. That has been discussed by and approved at the executive committee last week. The other issue, the other issues locally that I just wanted to draw attention to were the all-age commissioning strategy that is currently being approved at the executive, which also includes ensuring that we are getting the most value from our commissioning in terms of ensuring that services are fitting around the needs of the community, and that we reduce the need to spot purchase, which means we can be paying differential amounts for services for the same kind of support for a resident. I also wanted to once again say how important for me the contribution that carers are making across the city. I met with the Carers Centre and some attendees at the Carers Centre a couple of weeks ago, and will be absolutely committed to ensuring that they get a voice either directly or via me, to ensure that they are being heard at the executive level of the local authority. And finally, just a kind of an announcement, really. There is a Health Mela, a multicultural health festival taking place this weekend at the Museum Gardens. Oh, it says Gardens of the Art Gallery, but that's the same thing, right? This 24th, that's Saturday, isn't it? It's Sunday, sorry, apologies. On Sunday, between 10 and 5 in the Museum Gardens, everyone is welcome, and it looks like it will be, if it doesn't pour down like it did today, a wonderful event. If anyone has any other questions on that report, the idea is to try and ensure that we're looking in both directions in terms of our meetings, and so we're looking backwards as well as forwards. But I'll happily take any questions that anyone might have or comments. I will therefore move on to agenda item 4, which is the update on the implementation of the dementia strategy. And I think, yes.
At item 14 of your report, you said the recommendations from the Healthwatch reports were included as an annex, and that you would be asking relevant board members for an update on progress at today's meeting.
Apologies, in which case, let's do that right now before we move on. Did you have things that you wanted to ask about those recommendations?
No, I merely want to make sure that there was the opportunity for an update if anyone had one.
Fine.
I didn't want us to pass it by.
In which case, I'm just reviewing whether there is anything from some of them are directly to us, some of them are to TUV. I don't know whether, yes, Bob.
It's okay. I was just prompted a question on the second page of that annex, where it says review existing resources, support services and gaps in the pathway, identify the most effective ways to support and fill gaps, including those best provided by the voluntary community sector stuff, VCSA. And yet that the recommendations are made to the council to choose. I wondered if there's a need for CVS to be involved there, as we're suggesting. How is the voluntary sector being involved? Should they not at least be involved in the conversation? That's a point. I'm sure they would be, but I think it's not made explicit there, and I don't know if that's something that's been missed or there's a reason for it.
Sarah, and then I'll come back to you.
Thank you, Chair. I just wanted to clarify that our colleague Zoe Campbell.
Literally was looking for her and she
it was
wasn't there.
just the timing because we thought we were moving on. She just wanted to check on a lady who just stepped outside and just make sure that she was okay. So just unfortunate timing that we scooted back to this item before that point. So Zoe, so that's just a timing issue. So Zoe may come back to that specific point, but I just wanted to add as well that in terms of the place board and our recommendations in response to the Healthwatch report, very explicit recommendation from us as a partnership that we would respond to all recommendations through our partnership model, through our partnership lens, which does involve the voluntary sector. So essentially we would do that in partnership in terms of the range of recommendations. And I think there was a discussion around that at the previous Health and Wellbeing Board. I think Zoe will be able to give us a further update around those discussions from the Mental Health Partnership, which has been the appointed partnership governance to lead those actions.
Thank you, Peter.
Thank you, Chair. I'll just pick up some recommendations from the first one around the cost of living. So consider ways of measuring and monitoring that action. The Population Health Hub is working on an update to its pack from last year, where we did a lot of work on, for instance, the number of people living in fuel poverty, the respiratory admission rates in different bits of the city in terms of connections with fuel bills. So we've got an updated pack on the way there. So that action is ongoing. The recommendation later on, about palliative heating help for those with long-term health conditions in Gloucester, that we're still awaiting to see whether heating on prescription has a strong evidence base. It's a pilot, but what we have been doing is working with general practice in the city to target communications via text message from the practices about the home household support grant, I think it's called, which is essentially the mechanism locally for supporting those with fuel bills. So to use that money in a more targeted way. So that's a very low resource a way of actually getting the resource where it needs to go. So we've been moving forward some of those actions. And then the second action on there around access to advice and information, not just those living in known areas of deprivation of the city. I would just emphasise the Council's Live Well website. I think Live Well is a fantastic resource, and I think the more people know about it, the better, as something that really provides super signposting for residents. So just wanted to raise that. Thank you, Chair.
Sorry, I will just come back on that point, because actually I think one of the issues, particularly in the second recommendation around the cost of living report, is around digital exclusion. And I think one of the main, Live Well York is a brilliant website, but if you are not online or can't afford the internet, it's a terrible resource, because you can't ever see it unless you go to the library. So I have already raised that issue with Live Well York, but there is a resourcing challenge obviously there as well. I'll come to you, Councillor Munson.
Thank you, Chair. I wanted to speak about that one as well, because we have been promoting early mental health support in the community. And I'm hoping that at some point we'll have a report back which tells us how that's going. Now, the digital exclusion issue is a big one. Young people tend to take to digital means of support for their mental health far more easily than older people, but of course older people equally need support, as does everybody else in the middle. Support placed within the community that people can get to easily, preferably without a referral, becomes very, very important and stops later problems arising. So if we can have that back at some point, that would be very, very useful. Thank you, Chair.
Thank you. And Zoe, apologies. Just as you stepped out, I stepped back in the agenda to the recommendations of the two previous Healthwatch reports. And then I looked for you to talk about the Breaking Point report from last time, and there you weren't. So apologies that I'm now going to just ask if you have any kind of brief update that you can give on the recommendations of the last Healthwatch report around the crisis line and the crisis support. I know that you covered some of this actually yesterday at the scrutiny committee. So if there's anything you can just briefly say to update us about the crisis support.
The crisis line service, we've moved a step further in our engagement with partners from the voluntary community sector. Sorry, for anybody who doesn't know who we are, that's Tees Esquire Valley Mental Health Trust. So we're working very closely with partners in the voluntary sector. So they are taking quite a lot of the calls certainly that go to support mental health rather than crisis. And that's meaning that the pickup rate, so the answer response rate, is increasing. But we've moved a step further with them now taking all calls. And then so they do the initial assessment, and then they're passing people on to the crisis support team who are based in Tuve where needed. Now, I don't want to raise expectations too high, because that was just a soft launch a couple of weeks ago. But so far, the evidence has shown that we've got quite a good turnaround in that, and that model's working really well. I think the other thing I would mention, because it did come up in terms of the response from the partnership to the recommendations, is that within Tees Esquire Valley Trust, we have also started an urgent emergency care pathway review as well. So we've set up a programme board that's looking at all the services that appear on the mental health urgent and emergency pathway. So that also includes crisis telephone support and also the face-to-face crisis teams, as well as inpatient.
Thank you. Councillor Webb.
Thank you, Chair. Thanks. I think that actually, it's great to see that you've really acted on what Healthwatch have said and made good steps so far. And particularly on the response line, the crisis line, it's good to see that there's going to be an improvement in the number of phone calls picked up, for example. I think that's really important. The other side of it is, of course, what sort of training and qualifications do these volunteers have when they're answering the phone? Because obviously, I imagine if you are in crisis, you're going to want to be assured that the person can help.
They work very closely with our qualified clinicians, and they have support available to them whenever they need it.
So they themselves who pick up the phone do not have.
So they are trained to manage support calls. So the two voluntary sector organisations that we're working with, the people that they employ to work on they are employed staff. They aren't voluntary. Well, they could have some volunteers adding support in somewhere as well, but it's primarily paid staff. They do undergo training to deliver support to people over the phone. The bit where it gets into, is it a crisis? That's the bit where they can tap into support from our clinicians where they need to. So if they're unsure about anything, have any questions, and are not sure if they do need to refer directly to the crisis clinicians, to have the clinicians on hand. We're co-located where we can, but there's access via the phone as well. So if they do have questions, to have that support available to them. That's all part of the contract.
And can I just follow up on that? Because I think that it'd be great to see how that works over time. There's no point in picking it apart right now, because it's brand new, isn't it? But if we could maybe look at what the figures are for people getting through to someone, then people feeling they're being dealt with successfully at that time by that initial responder, but then actually, what is there a problem around that first responder? Then if they can't handle it, can they get access to, or do they meet the same barrier that they met before? So I suppose just in time, data on that would be really helpful.
Absolutely, Councillor, and I completely understand your concerns and questions. And these things did come up before we took the step to move even further into partnership with the VCS. So it was all considered then, and it has been written into contract performance measurements and expectations, but absolutely happy to bring a report in future, hopefully a positive one. Sorry, Chair, the one thing I did forget to say as well is that some of our professionals are delivering trauma-informed care to other professionals across the system as well. So how to deliver trauma-informed care in practice. And they've been working with people in the York Hub as well, with this professional staff base there, the non-TUV staff. So that's TUV staff delivering that support to non-TUV staff.
Great, thank you. And thank you, everyone. I am going to move on because of time. But if it's okay with the board and in discussions with Democratic Services, I will try and work out which elements of the Healthwatch reports that we need to continue to revisit. Any things that's been seem to be thematic issues that reoccur, and particularly the issues that have been the subjects of large levels of public participation. I think we should consider revisiting as often as the agenda time allows. So I'm not saying that we can do it every time in as much detail, but I think we should try to keep an eye on some of these issues because they are particularly pertinent to residents. I will move on, if that's okay now, to the implementation of the dementia strategy. Jamila, thank you for bearing with us. Sorry, you were on the edge of your seat and then you were off it. We are ready to hear from you with your update when you're ready.
Thank you, Chair. And I think Fiona has joined us from Dementia Forward, who is going to give us an update on the dementia strategy. Just to give those who may not be aware of the strategy came in around about 12 months ago to support people with dementia, their carers and families. It was a strategy that was really brought to fruition quite closely in a co-production and co-design approach to it. And we have a clear action plan and a steering group in place, Chair, to help deliver some of these. And Dementia Forward are going to talk about one way we're actually delivering some of our pledges in the strategy around the early intervention and support, and the work we're doing quite closely with our ICB and Nimbus health colleagues. So I'll hand over to Fiona.
Hello, so I'm Fiona Andrews and I'm here today instead of Jill Quinn, who can't make it. She's the CEO, so I might not be able to answer everything, but I'll have a good go. So yeah, Dementia Forward, we've held the commission service for dementia support throughout the whole of North Yorkshire now for, well, we've been around for 11 years, and some of that's been commissioned and some of it hasn't, but up until a few years ago, we didn't have the whole of North Yorkshire, but now we do. So the way that we offer support is, well, if you have a look at this first page on agenda item 4, I didn't do this, by the way, but the way that kind of this explains how people approach dementia when they're kind of waiting for a memory test, or whether they've approached their GP and they have this kind of really long wait before they have a diagnosis or not. So it can be just a complete and utter minefield, and that is what we kind of were told, and we try to kind of address that. So what we do is every single time somebody comes to a junction, we try to fill that with an actual person. So the grassroots of Dementia Forward are dementia support advisors, and these are the commissioned members of staff who literally go into people's homes and actually help them to work out what's actually going on. So we also have a helpline, so Monday to Friday 9 to 4, you can pick up the phone and you can call and speak to a trained member of staff who will then kind of listen to what you've got and maybe offer what we may call a bit of a triage system. If you do want to refer into our services, well, then you are allocated a support advisor. Because North Yorkshire is so absolutely massive, we've actually broken it down into 8 lots. So the support advisor that you will be allocated will actually come from the area that you live in. That's because we recognise that kind of where you live actually has an impact on your dementia and your well-being kind of going forward. We also support people pre-diagnosis, so you don't have to have a dementia diagnosis in order to refer into our services. We appreciate that there is a huge waiting list for memory assessments, and we have tried to fill that gap there by offering what we call brain clinics, memory services, which are kind of day services where people can actually drop in and speak to a trained member of staff and get some peer support and have some offer of support around that. Yeah, our support advisors will actually work with the family and the person right the way through till we're not needed anymore. And we will sort of help to support move into care, or helping to get the appropriate care within the home when that time's right. We know that dementia is a movable thing, so it's not static. So our support advisors will be there, as I say, at every sort of junction in order to help when there is a shift in the person's kind of cognition. And that's usually where kind of crisis comes into it. What we see ourselves as is being able to take a huge burden off the health system, because a lot of the times people will access health for issues that actually health can't actually address. And so we do have a lot of people who will ring the crisis line for behavioural matters, which actually, unless you can medicate against, really doesn't make any sense at all. So we're trying to kind of formulate a plan where maybe we could work more closely with health in order to kind of have that shift, so that people can be referred into us rather than be kind of referred into doctors and nurses who might pick up behavioural issues, which really isn't what you're there for, really. So yeah, we would like to kind of do that a little bit more tightly, I suppose. I think one of the things I would like to raise here is that our North Yorkshire Commission is for 10 years, and that really allows us to sort of invest. So if City of York could kind of look at the commissioning for being kind of long term, we do see the benefits with that. What it does allow us to do is to train members of staff to a higher level, knowing that we're going to retain them rather than kind of them looking for other jobs when the commissioning is kind of just about to run out. And we do in the North Yorkshire area have members of staff who've been with us for a long period of time, in which case they are pretty specialist in the work that they do. And that also gives reassurance as well to our clients that the person who they're speaking to is kind of going to be around for a long time. So we're a signposting agency as well. We can't do this alone. What we really want to do is to signpost as well to other agencies and organisations who do things that we can't do. And a lot of people with dementia, not just dementia, but with other stuff, when the diagnosis hits and they are dealing with a lot and they have a lot of information that they need to process, sometimes just haven't got the ability to read through all the stuff that they need to do. So we try to make everything like that as simplistic as possible. And what we do is we try to introduce the information that they need at the time that they need it, rather than bombard them at the beginning with absolutely everything. So that sort of takes away the anxiety and the stress away from kind of the dementia journey. We also have a dementia specialist nurse who provides that link between health and social care. And she also gives a lot of support to our support advisors for when things kind of go a bit tricky. Once again, taking the burden off the health system if we possibly can, because a lot of things just mean a little shift in medication or advocating for the person who hasn't really got a clue where to go. So what they do is they just bombard their GP all of the time. We also have a lot of wellbeing services around North Yorkshire. So that's a big part of kind of what we do. We have cafes and we have hub clubs, which are days of respite, and they're bespoke around the people who attend. And we also run a specialist young onset service. So that's specifically for people who have dementia under the age of 65. And we know that the diagnostic rate for people under the age of 65 is very low. And we're sometimes told in areas that, oh, there's not really a need. We haven't really got a lot of people with young onset here. And we actually set a service up, and then the next minute we're overwhelmed with people who up until that point have literally had nowhere to go. So we've got a campaign, a campaign that started last year. If anybody wants to have a look at it, it's on our website. But yeah, we're supporting the dementia strategy in York by being able to kind of do all the great stuff that we do, and hopefully long may it continue.
Thank you, Vicky. If I can just come in on a couple of the things that Vicky then mentioned in terms of commissioning. We have agreed collectively with ourselves and the ICB that we are going to look at commissioning jointly. We commission a number of services to support that early intervention approach really with dementia, and going forward we're going to look at how we can jointly commission in line with the action plan and what people said in the strategy about having a seamless approach to delivery. The other conversations we are actually having with our clinicians is around a working diagnosis. We know people can wait a while to get a formal diagnosis of dementia, and we are just working with our primary care colleagues through our quality group chaired by Michelle Carrington around how can we ensure people get that working diagnosis so that support can start sooner. Services like Dementia Forward and others actually support people without a diagnosis, but there are others that actually ask for one, and that moving towards a working diagnosis will help people to access a whole range of services that otherwise wouldn't be there. But it doesn't negate the fact that we're still working quite closely with Tube and others around ensuring people get a timely diagnosis, because that can open up access to clinical drugs that may help some people, especially our early onset dementia residents. So there's lots of work ongoing, but I hope this provides some assurance that we're working through our dementia strategy and the action plan agreed.
Thanks, Jamila. Councillor Runciman.
I'm sorry, I didn't catch you. The adoption of the dementia strategy is something that I pushed for a very long time, and it's very important to me that it not only happened, but made a difference. And from what Fiona said, it is making a difference. But as two things, Fiona, if I could ask you, one is, and I think Jamila's mentioned it, do we feel that early onset dementia is getting better and earlier diagnosis? And the second question is, how about the development of the hubs, the dementia hubs? Is that going ahead in a satisfactory way? Is it spreading around the city? I wonder if you could update me on those two.
Do you want me to update on that, Jamila? Yeah. So with regard to the hubs, yeah, these are things that are popping up sort of all around North Yorkshire. And we have started to set up hubs actually in York. So we've got a hub in Acomb, we've got a hub in Pocklington, and I think we're just about to set up a hub in Greenhampton. So these hubs are really well attended. So it's, and I think it's because it's something just a little bit different in so much as when people go there, they are at a specific point of their dementia. So we know that dementia is kind of movable. So not all services are appropriate for everybody at all times of their dementia. And we kind of recognise that. And what we try to do is to move people seamlessly from kind of one service to the next as their dementia progresses, so that they don't feel that when things happen, they're just dropped. And also we work with partners as well who kind of can take that on board as well, sort of when we can no longer sort of access that. But yeah, to answer your question, the hubs are really well attended. In fact, we've got waiting lists at quite a lot of the hubs. And that's because I think they're run by specialist dementia support activity workers who really put a lot of time and effort into making it right for the person, so that when they come in, the dynamics are right, and the stuff that we're actually doing with the people is different and it's appropriate for them. And I can't remember.
Early onset diagnosis.
So early onset. So early onset, do you mean people who are under 65, or do you mean just early people who are early on to get their diagnosis? Sorry.
Am I right in thinking, Councillor Runciman, this is about underdiagnosis of dementia in younger?
It is, and particularly of early onset. That's where the difficulties come, because it sometimes arises when at an age when people wouldn't think that it's going to.
Yeah,
that's the problem.
Yeah, and I think probably the more well known that we're getting to be, sort of in York and in the wider North Yorkshire area, I think that's improving, because I think a lot of the times what we found is in certain areas, and especially sort of in the rural areas and stuff, is that unless you set up a service there, people kind of seem to support themselves in communities. And a lot of the time they're doing really, really great work. And what we can do at times like that is we can go in and we can support them to actually do the stuff that they're already doing. So what we found in some areas is that people are running a cafe already, which is like a community cafe, but they have quite a lot of people in there who are, you know, local to that area, who are attending the cafe and they've developed dementia, and people are kind of running out and doing their prescriptions and checking up on them and things like that, keeping them at home. They don't necessarily want any help. But what we can do then is we can then offer support, and we run what we call kind of an outreach service, which is where we can go into the cafe, we can give them all the training, we can give them all of the information that they need, and then we kind of step back and let them do it the great way that they are. But they've got us in the background to be able to sort of come to when things might need when they need any support.
Yeah, and Councillor Runciman, we do have data to show that we do have quite a number of under 65 who identify themselves as having dementia. There is some work still to do around getting that early diagnosis, because there are waits for diagnosis. Hence why I talked about our working diagnosis just previously, about working with our public health, our primary health colleagues. But there is work ongoing with Zoe and her teams around how do we ensure and how do we make sure that those people that are the highest risk are identified early to getting a diagnosis. But that work is ongoing and will remain a priority.
Thanks, Jamila. I'm going to bring Sean in 1 second. I just wanted to pick up because I was going to say there's a similar point to Councillor Runciman around the diagnosis levels, and the fact that as a city we think we have a lot of undiagnosed cases, and just if there's anything from a primary care perspective or a community perspective in terms of progress or identified challenges there. And then the other thing I was going to raise, because I'm going to raise it whenever I can, is just anything you can add around support for carers, in particular around how we keep people in their families, in their communities for as long as possible. I met a lady at the carers group who is 80. She is looking after her husband with dementia on her own. She was a little lady, and her husband has physical needs as well as I think it was Alzheimer's that he had. I do think that she is managing on her own, but she also said there is a real problem with respite. She'd gone to the carers group, which was a 2-hour meeting in the centre of the city. And I asked her at the end, I said, so who's with your husband now? And she said, oh, I've just left him on his own because he's normally all right if I put the politics show on for a couple of hours. Actually, that was because she can't get respite for short periods of time, or unless she books it a number of months in advance. That doesn't work if you need to pop to the doctors or, pop and look after yourself or get a bit of respite for yourself just for half an hour or half a day. There were a lot of stories about carers who were at the end of their tethers, and the more we can do to support them to ensure that, their loved ones can stay with them and that they get the support themselves so that their own mental health doesn't deteriorate, I think is a real challenge. But I think I just wanted to make sure I'd raised it with you while you were here. And Jamila knows because I say it to her all the time. But it is something that when we're looking at this and looking just at our wider voluntary sector response, that we just ensure that whatever we can do to join things together and support everyone, and we're doing as much as we possibly can. I will bring Sian in if that's okay, because she's been waiting.
Well, and thank you, Councillor Coles, because I was actually going to bring in the same issue around carer support, and particularly when it gets to a point where going out to activities, getting out of the house, doing things together, doing things separately becomes a challenge, and actually people do find themselves more stuck in a household situation. I think there's some very specific issues that come through from carers about social care support and whether or not they can rely on that to enable them to access respite for themselves, whether it is just nipping down to the shop to buy bread or getting a haircut, any of those sorts of things, and how possible that is. And is our market here still strong enough to provide people with regular, consistent care in the home that enables them to feel confident they can rely on it? I think we also have a number of people speaking to us from other voluntary sector organisations about what happens in situations where a relationship was already quite difficult before dementia became part of it. And what happens, and whether or not carers in those situations where, for example, there has previously been suspicions of things like domestic violence, is the carer and the person with dementia both listened to in that environment and supported with whatever is coming their way? I know I've been involved in lots of really interesting discussions about violence and aggression in dementia, and how much of that is a failure to genuinely engage with the person with dementia and understand the frustrations they're experiencing. But it is a reality for some carers, that violence and aggression, and how that is managed and how those individuals are supported with that. So I think there's still something for me and I'm sorry, this has been a bit rambling because I'm still kind of working it out in my own brain, but there's still something for me about we've just been given loads of information, which is all brilliant and all sounds great. But is there some clear information we can see about the strategy itself, the action plan, and the progress we are making with those issues in a way that is a little more concise than this, so that we have that reassurance and we are aware that we're picking up these issues, or if they're not reflected in the action plan, we know what we want to add in to think about for the future, because we've clearly spent a lot of time on developing the dementia strategy. It should cover everything, things like carer support, household situation, preventing carer breakdown should be there, and I think it would be good to kind of just get a sense of where we are on that.
Great, thank you, Sian. Sarah, did you want to come in?
Thank you, Chair. It was just on that point, and Jamila may want to say more about this. And just also, you'll notice in the next item that we did discuss the dementia strategy at the place board, and we were able to have a really deep and meaningful discussion actually, and really make a commitment in terms of the next steps as a place board. The point I wanted to make was in response to Sian's question around the plan. I think it's the delivery plan that sits underneath the strategy, which is in development, and that is due to go to the next Dementia Steering Group meeting. So I think it's just timing in terms of having that available for today. It's also a good opportunity to plug, I think we've already had one event plugged that's taking place on Sunday. There is another event taking place on Monday, the 25th of September, which marks the first year of the strategy. And again, the delivery plan, we're hoping to be able to take that to the event. That's at the New Eswick Folk Hall on Monday, 10 till 4. Thank you.
Great, thank you, Sarah. I'm just going to invite, does anyone else want to speak before I ask Jamila and Fiona to come back, because I'm quite keen to move on before we get too far behind. Jamila, did you want to come in, and then I'll come to Fiona?
No, that's fine. I think in response to Sian, yeah, as Sarah says, we were updating a plan. There is a plan in place, but we're updating it. Absolutely does include carers and supporting carers. We've just done the carer survey around short breaks, because what we didn't want to do is commission short break services that are not what carers want. So that survey will hopefully give us a lot of insight into what carers' needs are, not forgetting the digital offer that we're offering people with dementia and their carers. But I'm happy to come back, Chair, with an update on a clear update on where we're at with the plan and what the gaps are. But I just wanted today to be, these are all the work that we're doing and how people can access some services. So hopefully that's give colleagues some assurance of the work that we're doing.
Thanks, Jamila. Fiona, do you want to add anything else?
Just really quickly, we've also picking up on what Sian said about kind of behaviours with dementia and how they can kind of implement, they can really have an impact on kind of family dynamics. I run all of the education sessions for Dementia Forward, which we are rolling out now. It's become really, really popular, which covers all that sort of stuff. So we really encourage communities, organisations, literally anybody who wants this. And it's pretty much become my full-time job now, where we're finding that more and more people who are actually living with dementia or supporting people with dementia, or they have an organisation where they're recognising that people with dementia are actually accessing their services, but they don't really know enough about dementia to actually really give that proper support. They're booking me in for education sessions, and I'm going there and I'm kind of giving that real quality, hopefully, awareness for them to be able to kind of manage those symptoms, or then even be able to refer into us kind of if they need to do that. So I run all of the training and education for Dementia Forward as well, which hopefully will fill that gap a little bit as well. Thank you.
Great, thank you for that, and thank you everyone for your contributions on that. I'm going to move on to agenda item 5, which is the report from the Health and Care Partnership. Sarah.
Thank you, Chair. So you have a update on the partnership in terms of our discussions that took place in August. I believe a previous report went in July, so it's just 1 month of the partnership over the summer period. Our next meeting is in fact tomorrow. Just a reminder in terms of the place board, in terms of our focus areas, this is the board of our health and care sort of executive leaders. We have a number of other elected member leaders as well around that table, very much around delivering our place forward plan. 6 priorities for us: integrated community offers, integrated urgent care, primary secondary care interface, children and young people, integrated prevention offers, and broader social and economic development. So just to give a whistle-stop reminder of our focus and bringing about behaviours that bring about mutual accountability for our population. You'll see at the last meeting quite a packed agenda. We've just been discussing the dementia strategy here. As I said, really meaningful discussion and commitment to develop an integrated community-based offer for dementia care, supporting that shift around early help and prevention, particularly recognising the burden on diagnosis services. And we did have that debate, and I've taken that through to the clinical professional forum of the integrated care board across Humber and North Yorkshire as well, in terms of how we can ease the burden on diagnosis services by offering that working diagnosis approach and ensuring that people can access that pre and post diagnosis support, even recognising those delays to waiting for diagnosis. So really positive conversations, and also ensuring that we are aligning this with other community work that we're doing. So, for example, developing our frailty hub, which is part of our model as well for older people. A number of people living with frailty also live with dementia. So really important that we recognise people are whole people and develop services that meet their needs. Another big focus was around winter planning, just outlining the expectations. We spend the summer planning winter, and then we spend the rest of the year surviving it. And winter always seems to get longer and longer each year. And we will be discussing this in some detail at our place board tomorrow. So we'll be able to give an update on that next time in terms of our focus. Just to give a flavour of some of the focuses, things like ensuring that we have resilience across the NHS in things like same-day emergency care, those frailty services I mentioned, community beds, intermediate care, also virtual hospital models as well. Technology does enable us to support consultant-led medical care in people's homes more and more, so taking full advantage of those models, urgent community response, single points of access, and also responding to surges in acute respiratory illness. We saw that last year, so we're very much preparing to respond to that again. And one of the big features of our plan this time, which we didn't have to do but we wanted to do, was develop a whole system resilience plan, which encompasses all of our preventative services as well, our voluntary sector services, our public health services as part of that. So we will be discussing that more next time. I think just to sort of share as well, one of our real key focus areas is recognising that as a place board, we do need to keep an eye on what's happening now in terms of things like winter, making sure that we're delivering good quality, high-performing services, but we also recognise we need to do that whilst shifting the dial on the distribution of health to the population, which is much more longer term. So we do try to get that balance in our place board, and you'll see the next update in the pack is around our health inequalities projects, really integrated approach in terms of targeting those people, those communities, those families of the greatest need, and targeting, making best use of our resources to get the greatest health benefit for all. And we mentioned earlier our Health Mela is taking place on Sunday. It's the Artist Garden just behind the Art Gallery, so you can access it by the Museum Gardens. That's the direction in there. Is one of the projects funded through the Health Inequalities projects. Also, some examples of the work we've been doing more broadly that are less about services and more about our social and economic responsibilities as a place board. We have a real focus around workforce. Very exciting to promote our event on the 4th of November, where we will have health and care employers, as well as our colleges, our universities, encourage everybody to come and engage in that. We'll have interviews on the day as well, opportunities for people to access employment in health and care services, but also hear more about the education opportunities. Really important with the National NHS Workforce Plan announcement, many more places around nursing and medical and allied health professional places. So our universities, our medical schools will be there to talk to people of York in terms of being able to access all of those opportunities going forward. Work of the Population Health Hub is ongoing. We heard from Peter earlier with our update on the cost of living pack. Some recent work that has been done hot off the press is around attendances due to mental ill health, and something that we've been looking at as a York Health and Care Collaborative, which is in fact one of the subgroups of this board. We also signed off the anti-racist strategy led by City of York Council colleagues, partners supporting that, and as an ICB, which I'm here on behalf of as well, ensuring that we are plugging all of our NHS resources into that as well, and our existing networks that we have in our NHS organisations. I think finally, just to mention again, in terms of our broader work around social and economic development, recognising the long-term need to focus on the growth of the population in York, so embarking on a joint health and care estate strategy, and ensuring that we are able to keep pace with the growing numbers, but also the ageing population as well, and that we are building a city that is fit for the future. Some really exciting prospects there, equally around addressing sort of climate and sustainability plans and affordable housing as well for our key workers. So lots going on. That's a lot for 1 month over the summer, and more to come. Thank you, Chair.
Thank you. Can't see anyone indicating. I'm just got what I just, from my point of view, when I was looking at it, I just wanted to just pass on the in terms of supporting our workforce to deliver over the winter. Certainly from me, a huge appreciation to all staff who are working in the health service and in health and care services. They have been through such a difficult few years, and I know that sickness levels have been high, and morale has been challenging. Therefore, I just think it's really important that we pass on our appreciation for the work that people are doing. You know, we've got the cost of living data pack, which I thought was timely. I actually wanted to ask just what consideration has been given for the cost of living pressures for staff within the service, just in terms of, you know, the pressures on the cost of living are you know, do not exclude people working in the sector, and also those who might be carers, and the pressures that they might also be, just whether or not you can just reflect on those things as well. But I'll pass over to Peter, who's indicated.
Thank you, Chair. Thank you, Sarah. I think winter resilience is always going to be an issue for us, isn't it? We did decide this year, let's start our planning on March the 1st. Let's make, you know, the earliest possible dent in terms of preparedness. It's the point of vaccination. We've had 2 or 3 years now of vaccinating our population more than we ever have done for a variety of things. And I do feel a little bit about vaccination fatigue within the population, about people essentially not coming forward to the extent they would do. And particularly, you know, with the data coming through from New Zealand and Australia, is not as concerning as it was last year, actually. This year they haven't seen such a peak, but still it is the best protection that we do have, particularly for at-risk groups where the rest of their cohort aren't covered. So for 50 to 64-year-olds, at risk 50 to 60-year-olds, 64-year-olds are invited for the COVID vaccination, but those of that age who are not at risk aren't. And we know actually that when everyone is invited, everyone comes forward. So I guess it's just a plea through all our services to emphasise that eligible people getting jabbed, getting both COVID and flu, it will be the way that we just minimise health and care pressure, morale of our workforce, all that sort of thing. So keep on plugging that public health message, I guess, of getting people jabbed. Thank you.
Thank you, Chair. Just following on from that as well, I think there's a message to employers as well that whether it's COVID or whatever, it shouldn't be treated like any other cold, which often in this country, we have a real problem with if you're ill, you still struggle your way into work. And then what you do is you make everybody else ill, and then everyone's productivity is down. And it's not good in the long run, and it's not good for health colleagues as well. Just on the annex, I was just looking through the report, and in the AOB section, and you talked about it, about the careers and volunteering events taking place on the 4th of November. I think that's fantastic. But how are you advertising that, and who have you reached out to get them in the building, I suppose, is the question.
I'm just going to take Councillor Runciman, if that's okay, and then you can come back on all of it together, if that's all right with you.
Mine's more of a comment than a question. I'm pleased to see that we're looking forward to the health and care infrastructure that will be needed in new developments. I was at an exhibition about the development north of Clifton, and I was pleased to see there that there was recreational space and educational facilities, etc., etc. But I just want to say that we do still have areas of the city which don't have health and care infrastructure even now, like Weldrake, where the surgery is closed. And I hope that, as well as the looking forward bit, we'll look at what's happening now and what isn't there now that needs to be there.
Thank you. Sarah, would you like to come back on those things?
Yes, thank you. Thank you, Chair. That gave me a few moments to consider Councillor Webb's questions, which I had a momentary blank on. And I may not have a satisfactory full response because I've slept a few times since I looked at the flyers and to check the advertisement. But what I can say is that all of our organisational partners, including our further education colleges, our schools, have been asked to circulate it to their young people. There is promotion on social media as well, in terms of our ICB and other organisations have also been asked to promote it via social media. However, I will take this opportunity to ensure that we do further plugs, and it might be that we can actually include some further promotion through some of the other council communications channels as well. And if council colleagues would be happy to support me in promoting that through our wider public routes, then I would be very happy to take you up on that. Thank you. Just remembered there's two questions. I think that second point is probably a comment, isn't it, more than a question in terms of support for that approach. In terms of our growth, it's fantastic that we are growing. Not all towns and cities are. In fact, indeed, a number of my colleagues have got the opposite challenge in terms of people leaving the city and the town. In terms of York, our local development plan, I think it's very positive that we have that local development plan, and that we are now planning together in terms of recognising where services are stretched and the need to think differently and think beyond the traditional service models, take the opportunity to build into those models services that support, for example, the ageing population, which is set to increase really significantly in the next 10 years. So and that work is very much built around the buildings that we have now, where they are across health and care, where those health and developments are looking to be situated, and what that then means for future estate.
Thank you. Have I missed anyone else who wanted to come in? In which case, I'm going to move on, if that's okay, to agenda item 6, which is our discussion paper on health inequalities. Peter.
Thank you, Chair. So a very brief overview of this paper. This is really setting a bit of a benchmark for our new health and wellbeing strategy that the board approved last year. And the first goal within that strategy, the overarching goal, is to reduce the gap in life expectancy and healthy life expectancy between the richest and poorest within the city. And so this paper sets out a bit of a benchmark about, well, what's the size of that challenge? So in many ways, I hope it will be helpful for us for future planning. And as much as the discussion today, it does go into a little bit of the public health data behind that. And apologies for that, really, because I think the evidence is where we need to start in terms of that gap. Future meetings of the board will have updates on progress against the 26th, I think there was 26 actions within our action plan. The point of those actions is to get us to goal number 1, is reducing that gap. So I don't think we go out and do actions to try and reduce the gap directly. We go out and do the actions that we've set, and that the result will be the gap reduces. The report talks a little bit about the gap in life expectancy and healthy life expectancy. The data is there, and I won't go over it extensively. Often different figures are quoted when we talk about the gap in life expectancy within York, and you will hear different numbers. People may sometimes be referring to different years, but the report just sets out that actually are a couple of ways you can measure it. If you measure it in terms of a ward gap, you see that the gap in life expectancy in York between our two different wards is around 11 years for both males and females. If you measure it in terms of bits of the city which are more or less deprived, not thinking specifically about council wards, the numbers are a bit different. They're about 9.7 years for males and 7.9 for females. So it just explains a little bit about where that those numbers come from, but also then talks about the trends. At point 17, it demonstrates that healthy life expectancy for females started the decade that we've just ended, started 2010s, higher than males, but then declined to lower than males by the end of the decade. And male healthy life expectancy was broadly static. And then life expectancy over 2 decades, we see really 3 trends. We see a gradual improvement in the 2000s. We see a sort of a static trend across the second decade of the century. We see, and this is the graph at point 18, a larger gap in life expectancy at the end, the most recent data versus at the start of the century. And then we also see the gap between the most poor and the second most poor decile is actually the largest gap. So actually the inequality increases as you go down. Point 19 talks a little bit about, well, if we've got the most proximate causes for that gap, what are they? And actually that is where the evidence is very strong. It shows that 2/3 of the gap in life expectancy is due to 3 disease areas: cardiovascular diseases, respiratory diseases, and cancers. And there are very good international evidence showing that, for instance, 30% of cancers are preventable, 60% of respiratory disease is preventable. So actually there's a huge amount of preventable disease underlying our gap. Point 23 talks a little bit about some of the behavioral risk factors which lead to those diseases, and it will be a very little surprise to many people around the table that you can identify tobacco use, high blood pressure, and poor diet as underlying a lot of that inequality. But then we go on to make a point at point 26 that those are not necessarily things people are choosing of their own free will. Conditions within society lead to those types of choices and the types of lives that people lead. Point 26 goes on to talk, therefore, a little bit about, I guess, the wider determinants of health which underlie those things. At that point, I'll make just a slight correction. At point 26, older people in poverty data gives a data for Clifton ward of 16.6%. It should then read for Heweth without ward 4%. So just I missed the without. I was without my without. So just to clarify on the ward there. And then just conclusions at the end. I think we need to be realistic about the fact that we're not merely trying to reduce, but we're trying to reverse the increase in the gap in healthy life expectancy. That's an even bigger task. It's going in the wrong direction, and we're going to have to reverse that trend. But we do lay out the fact that there's good evidence showing you can make an impact on, for instance, high blood pressure across the population within a 3 to 5 year window. But there are other things underlying why some populations have higher blood pressure, which you can't actually tackle within a 3 to 5 year window. Marmot principles that are listed there would suggest you need to be making changes over a 10 to 15 year window, which is why our strategy set that 10-year time period. And so the board are being asked to note this baseline data, note the fact if we set ourselves a challenge, we probably better understand what the scale of that challenge is as we commence that journey, as the strategy gets reported on. So just open for comments really on the data within the paper.
Thank you, Peter. Councillor Webb.
Yeah, thanks, Peter, and thank you for picking up and responding so quickly today when I was reading the report and I saw that older people in poverty in Heworth was at 4%, and I thought it felt wrong, to be honest. So I'm glad that you, as a Heworth ward councillor, I'm glad you sort of spotted that one. Yeah, I think this is a really important piece and sort of sets a scene for a lot of work coming forward, really. I mean, if you look at paragraph 18, I think this is one of the most apolitical political paragraphs you could imagine, really. I mean, where it says essentially at the beginning of this century there's a gradual improvement, and then in 2010 there was a change. Make the conclusions that you will, and I think from that, one of the biggest thing that pops up is that the most poor are hit the hardest. So there's been an impact on the majority of people that has changed the health outcomes for the majority of people for the worse. But actually, if you are in that lowest group, if you're in that hardest hit group anyway, the pressures are even greater, and that's clearly being shown here. So I think this really sort of reflects a lot of what we want to do in the council in terms of embedding health through everything that we're talking about, and also looking at what we can do as an authority, and specifically looking at what we can do in terms of targeting our support at the most vulnerable and at the ones who need it most, because we all have to accept that, you know, we're one of the worst funded authorities in the country, and this is a difficult thing for us to deal with, but hopefully we can target our support in the best way possible using things like this strategy, and that will make a real positive difference. I know public health budgets are really stretched, like every other thing is really stretched, but I just really encourage us to focus on a needs-based approach as much as we can. So thank you.
Thank you, Councillor Webb. Councillor Runciman.
Thank you, Chair. Two things. Firstly, I'm glad to look at the sub-ward issues. I represent a ward where one side of the river is very deprived and the other side of the river isn't. And you can't just take it by ward. You've got to look much more deeply than that. And the second thing is, this really says to me how important the work of the public health team is, because a lot of this is behavioural. You choose whether to smoke tobacco or not smoke tobacco, or anything else for that matter. You choose the amount of alcohol intake you have or don't have. And the work of the public health team is absolutely crucial in helping people to change those behaviours and hopefully live longer and healthier.
Thank you. I just before I come to Councillor Webb again, just on that issue around the kind of more micro level understanding of deprivation across the city, that almost certainly is the way to try and explain and justify the need for higher levels of funding needed across the city. And it certainly will be how we start the process of reducing some of our health inequalities. I was particularly struck by the differences around healthy life expectancy versus life expectancy. It's not good enough to just be living longer and for us to just narrow the gap in life expectancy, but it would be much better if people are living healthier lives for longer, rather than just living for longer and potentially in great pain and discomfort. Councillor Webb.
Yeah, thank you, Chair. I'd just like to come back on something Councillor Runciman said there about people choosing to smoke and people choosing to drink. You know, personally, yes, I choose to have a drink every now and again. I'm happy to admit that. If you are in a situation where you are in poverty and you are a very vulnerable person, I just want to make the point that I can't begrudge someone doing something like smoking if it's the thing that de-stresses them, if they're in an environment which is very, very, very stressful. I think you're right that actually we have to do everything we can to help them make better choices. But I think the bigger question is about de-stressing their environments, really. I think that would be something that would be really, really helpful. And on another point related to that, in terms of, you know, we're talking about long-term strategies here. With my exec for children's hat on, if a young person is in a household where they're seeing smoking, they're seeing drinking, you know, what is choice? What is influence? You know, and I think that actually there's something that needs to maybe be in here about how we're helping families and young people. But my bigger emphasis would be, let's de-stress the environment. That would probably make things a little bit easier in that respect.
Martin.
Thank you, Chair. And probably following on from Councillor Webb, really, I think it's really important. We all know around this table that it's very difficult to change behaviour the older we get. Actually, concentrating our efforts on having a good start in life is absolutely significant to changing the issues around poverty that doesn't change in a decade. It takes decades and decades to change. So our investment needs to start now. We won't necessarily see you know, the fruition of our investment and for many, many years to come. But I think really trying to concentrate on what we can do for children in the city will make a considerable difference for the long term.
Absolutely. I will take Fiona and then Sean, and then any final quick comments, and then we need to move on.
Yeah, just to add on to the prevention side of stuff, I think a lot of it does come down to education, because a big chunk of my education sessions around dementia now are geared towards preventative measures, because we do know that there's, well, statistics have shown that around about 40% of all dementias can either be delayed or actually prevented due to good lifestyle choices. And I think public health can actually help us to push out that message as well. So, for example, quite a lot of the places that I go to, people will approach me afterwards when I do my little bit at the end on preventative stuff, which is all about physical exercise, you know, the stuff that we kind of not encouraging sometimes with kids because we're not giving them the space to do that, or they live in a place that it's not easy for them to access that. But it's also good diet, not smoking, looking after your heart, your blood pressure, all the stuff that kind of public health actually do now already. But what has become apparent to me is that I think a lot of people are desensitized to that. We know that we should stop smoking and not drink a lot and eat healthy diets and stuff. And a lot of people have come to me after these sessions and said, if my GP told me that this would reduce my dementia risk, I might sit up and sort of listen. So maybe we've become really well established in knowing what we should do. It's just hard sometimes to put it into place. But if we put a different slant on it, we might be able to kind of have a little bit of a double whammy.
Thank you, Fiona. Sean.
I think this is really interesting, but there's also a question mark in my brain about lots of meetings I go to. People tell me that certain people will die sooner than the general population in usual terms. So people with serious mental ill health are likely to die 20% earlier than the rest of the population. People with learning difficulties are likely to die 15 to 20 years before the general population. People who are neurodivergent are more likely to die earlier than other members of the population. So I think there was a kind of a question mark for me about what else with this, that this is a really interesting way of thinking about things, that healthy life expectancy is a really interesting thing. Looking at it on a population basis is a really interesting thing. But when you then drill down into the additional reasons why somebody might have a lower life expectancy, does that give us even more understanding and information about where we're going to be targeting our resources, our support, our advice and information, the kind of interventions that we can make that could genuinely transform people's lives? I think there's also something for me about the impact on individuals with particular genetic makeup around the things that they might be exposed to and the behaviours they might indulge in, if we'll use that phrase. I don't think that's the right term, but I can't think what is. But I think, for example, if you have an undiagnosed mental health condition, you are much more likely to take up drugs or alcohol or smoking to feel more normal. And I don't like the term normal, but I think that's how it is used in that context. And similarly, again, with ADHD and autism, we know that when people are trying to mask that behaviour, they are more likely to use drugs or alcohol to help support with masking. So I think there's some additional questions in terms of behaviour change and what we as a system need to do. And I don't think I've got a question, but it's just sort of a blur things in my brain. Could we add that into the thinking on this?
David.
Thank you. I'll take this opportunity just to point out, by the way, I'm not Chief Executive of York CVS, I'm Chair. I'm standing in for Alison. The paper said, discuss where and how the inequalities arise. Yeah, sorry, where to look for solutions is what it said in the paper. Well, we haven't got time to do that today. No. So what I would flag up is a very general point about the fact that this sort of data has been around for more than a century, going back to Seabohm Roundtree. Therefore, you have to think, well, why haven't we fixed it? And one of the issues is that actually changing people's behaviour is quite incredibly difficult. But from that point, you then have to say, well, what examples do we have of projects and approaches that have worked? And I am always keen to look for examples of things that work. So when I read in the press recently of a project led by a nurse called Anne Boriner at York Medical Group, working with homeless people, I was really struck by the fact that she has taken hold of an issue and said, we are going to find different ways of working with people experiencing homelessness, and we are going to work on their terms where they are. And if there are bureaucratic problems, such as they don't know their NHS number or they don't have a permanent address, we will overcome those problems. And that is the sort of approach that ultimately is going to make a difference. But the difficulty is scaling it up and making it possible for those community-based projects to work using peer-to-peer support in particular, rather than always expecting it to be done by someone who is in a paid professional position. And I think clearly the one thing that holds us back is knowing that every single service represented around this table is under terrific pressure at the moment. And we can say until we're blue in our face that we would like to move resource from the acute end to prevention. But we surely must have it as an aspiration based on these 100-year-old data sets to say, let us at least look for things that work and do more of them.
Thank you, that's really helpful. Peter, do you want to just come back briefly? I'm just mindful that I'm doing some terrible chairing today and we're really behind.
I'll be very brief just to say, I think this conversation demonstrates that this is very complex, isn't it? And there are many more things we could say about, absolutely, Sean's point differential sort of death rates, early disease rates across lots of different types of populations. The paper is focused to a great extent on geography, but there is demography and there is protected characteristics and there are inclusion health issues and all of those things. So really reflect those points. And Councillor Ronson's point about the work of the public health team, I think does reflect all of those things and reflects the fact that, as you were saying, David, there are some things which have a very strong evidence base that we can do to try and prevent, and we don't have enough resource to do things that don't have an evidence base, and we need to target as well. So I think all of these things, conversations should shape the approach to when we come back with the 26 actions and we find out what our colleagues have been doing, and we say to ourselves, is that at least as well as we can do, or are there ways that we can shape that? So hopefully that sets up a conversation on the strategy next time around. Thanks, Chair.
Thank you. We will return to this issue, no doubt, not least because it's a priority of the council plan. Sorry.
I was just going to say, do we need a workshop? I know it's a really bad thing to say, and it's really quick, but I think we need a workshop.
I think we quite possibly do. I'll discuss it outside of this meeting. Yeah, thanks. Agenda item 7 is the presentation around the adult and social care CQC readiness. Jamila, I'm hoping you're still there. If you could start, and I think you're Gabby.
Yes.
Yeah.
I'd love
Yeah, I'm still here. Listening to the conversation has been really interesting. And thank you, Peter, for that update on equalities and inequalities that exist in our city. So I think the next item, yes, Chair, is around CQC assurance. It is an inspection in any other name of adult social care services. We haven't actually had adult social care inspections since 2010. I think the last one happened in 2020, and these were followed by peer reviews. So and the peer reviews were in replace of any inspections. Children's carried on with their Ofsted, as everybody is aware of, ILACs and their SEND inspections. So this is new for a lot of people in adult social care who weren't around in 2010 and before. However, we just wanted to give the Health and Wellbeing Board an update on where what the assessment will entail, what they're looking for. Healthwatch are key partners in this with us, so we're working quite closely with Sean because it is all about individuals, but equally it's about the leadership and what part the Health and Wellbeing Board will play in some of those inspections going forward. So I'll hand it over to Gabby, who is holding and leading on some aspects of the CQC assurance. So Gabby, I'm happy for you to run through your slides. I'm not sure people can see the slides, but if you run through them and just give them the key information.
Thanks, Jamila. Gabby, we have paper copies of your slides, which were circulated in advance. So if you want to highlight the bits of it that you think are particularly important, you just need to press your mic to speak.
It's green, yeah, is that working? Yeah. Okay, perfect, thank you. Hi everyone, nice to meet you and apologies for being late, but I'm Head of Transformation in Adult Social Care. Okay, so yeah, as Jamila's talked about the CQC inspection that we are anticipating, I'd say any day now, but essentially any day, month or year now, we're not quite sure when the CQC are coming. So the Health and Care Act that came into place on the 1st of July last year now gives the Care Quality Commission regulatory powers to inspect local authorities and integrated care systems as well. So they have created a single assessment framework. Historically, the CQC had multiple frameworks that existed for multiple service types. For example, hospitals, doctors, surgeries, care homes, supported living services. There were many frameworks. There now stands to just be one single assessment framework, which means that all health and social care providers across the country will be held to the same, will be held account to the same standards and the same sets of quality and expectations. And the idea is, in line with integrated care, that it brings us all together and holds us all account in this for the same reasons. So the CQC have identified 4 key ambitions that they want, that they've embedded within their CQC strategy, the single assessment framework. So that's looking at people and communities, smarter regulation, safety through learning, and accelerating improvement. And they've identified that being able to assess local systems and looking at how we're tackling inequalities across health and social care will allow them to have a better understanding of the state of care across England. So within your slides, there are some legislation slides, and everyone loves legislation. So there's 3 pieces of legislation that are really important for us to feel ready for when the CQC do come to visit. The main one being the Care Act. So local authorities will be inspected under a number of sections within the Care Act of 2014. But we also need to be ready and have an understanding of the Health and Social Care Act 2008 and the CQC registration regulations of 2009. And that's because there is an expectation that as a local authority, we're compliant with the Care Act, but also that we have an understanding of how our providers in the community are compliant with their legislation. So we're sort of getting our head around those three pieces. So the framework is made up, there's a nice triangle within your slides that gives a diagram of how the CQC assessment framework will look. So we are maintaining, or the CQC are maintaining the 5 key questions. So they look at whether or not a service or a local authority is safe, effective, caring, responsive and well led. So they will stay the same. There are then quality statements. So for a local authority, there are 9 quality statements that we will be inspected under. And those are kind of categorized into 4 key themes. Then we've been advised of the evidence categories. So the CQC have looked at, I think it's 5 evidence categories that they will be using for local authority inspections. And then there will be specific evidence and quality indicators that apply for us as a local authority. So we can have a look at the 4 key themes that apply. So they are working with people, providing support, ensuring safety, and then leadership. And you'll see within those, there are then the 9 quality statements that will be looked at. In terms of ratings and scorings, I know everyone's always really keen to hear what will happen from a rating perspective. So at the moment, the CQC have assured us that we will receive a scaled score of 1 to 4 for each of the 9 quality statements. So we won't get a rating for each of the individual statements, but we will receive an overall rating. Moving forward, I understand from the CQC, once they've completed all local authority inspections for the whole of England, they will then start again, and then we will receive ratings under the quality statements and the key themes, but for now, just 1 overall rating. So the CQC, they're underway with their 5 pilot inspections. So Birmingham, Lincolnshire, North Lincolnshire, Nottingham and Suffolk have been identified as the 5 local authorities that are participating in the pilot. 2 have been completed, the 3rd one is midway through. So we are working with those regions to get feedback and to keep up to date and share best practice ideas and kind of brainstorm about how we can be ready here at York. So in terms of specifically what we're doing here, so we have facilitated drop-in surgeries for operational staff. So every 2 weeks on a remote team session, frontline staff can dial in. We are theming those. So for the first 4 sessions, we looked at the framework, the legislation and an introduction to the CQC assessment. More recently, we've started to theme those for interview questions. So helping people feel ready. So if a CQC inspector was to meet with them, how they can approach that and feel safe and confident and comfortable to do so. We've then began our face-to-face workshops. So as I mentioned, there are 4 key themes. So we are doing 5 workshops, 1 for each of the key themes, and then we will do a wrap up in the new year where leaders will be able to come and feed back to frontline staff about their thoughts and feelings in terms of compliance. As I mentioned earlier, we're also attending regional workshops. That's where we can share best practice guidance. We have a self-assessment, so ADAS and the LGA have worked quite closely together to develop a self-assessment that the CQC have said is not mandatory, but is very much encouraged. It's an opportunity for us to outline how we think we're doing under those quality statements. So we're currently on version 2 of that, and we attend a peer review session, which we're going to, Jamila and I will be going to that in about 3 weeks to present version 2. And that's where we get peer feedback about the quality of the self-assessment, what we can do to improve. And then when the CQC do announce they're coming, we will send them that in advance so they get an idea of how we think we are under the key themes. We've also then got an evidence list. So the CQC have identified approximately 80 documents that they'll want to see in advance. So we know what they are now, which is really positive. So we just need to make sure that we've got those ready and waiting and that they are up to date. So they have to be 12 months in date. So we'll identify where the gaps are and then get those ready for them. We are also potentially going to look at completing it or starting a task and finish group with our ICS colleagues so we can help them get ready for their inspection and they can help us get ready for ours, and we can share some knowledge about how that's going. And then I know that Jamila's looking to do a mock inspection or to organise a mock inspection for us early next year. And I think that's it.
Brilliant, thank you so much. I have one question, but if anyone else has it, if you can indicate, I'm quite keen to move forward quite quickly. Bob, sorry, Councillor Webb.
It's all right, Joe. Speaking from a children's perspective, the concept of inspections, it's horrible. I don't envy it all, particularly starting in this premise. And just one thing I'd say would be around preparing for this process. I think, we obviously need some inspection framework. There needs to be some oversight, and I can see the need for it. But at the same time, it is so much pressure on staff, day-to-day staff who have got a lot of work to do to just keep their jobs ticking along and doing what they need to do. The additional pressure of mock inspections and other things can be a lot. And I think it's just what I'd like to see is, alongside all this, you know, there are very valid reasons for a lot of this, but alongside this is a look at staff wellbeing and staff feedback and the pressure on staff, so that you don't get into a situation that everyone's so tense and so wound up by the preparation for the inspection that can have a negative effect on staff wellbeing, staff recruitment and retention, things like that. So I wonder, is that built into this process somehow? And if so, where and can it be made explicit?
Thank you. Before you come back, I'm just going to ask my question, and then you can come back on both of them at once. My only question was just around the themes and the points beneath them, that there is a particular point around sustainability, and I find that slightly challenging from the point of view of local government funding. And the proportion of our funding which we have to spend on adult social care because of the demographics of the population. My question was whether that actually does relate to in any way to funding, but just also whether in the recent children's inspection there was that's a similar requirement under your inspections around sustainability. And if it's not about funding, then that I guess is fine, but and it might also be about people and staffing and recruitment, which also would be very valid. It just struck me as, given the challenges of the budgets, not just in York, but across the country, that being inspected on something like that is difficult. And particularly, I wondered how Birmingham were faring on that respect. And if they did have any feedback from their own pilot inspection, I'd be just interested in how they responded on sustainability.
Okay, do you want me to come into that one, Gabby, around sustainability? I think there's two specific questions they're asking, because one, under the Care Act, we do have a duty to ensure that we have a sustainable market. Councillor Coles, hence why the commissioning strategy that went to the exec and the market position statement that is online are really key documents, because we do have a duty to have a sustainable long-term market and plans around provider failure, provider sustainability, which we do have. I think one of the aspects is around finance, so they will look at our financial management, and I think all the pilot areas are challenged with their finances, but equally I don't think they're going to mark specifically around overspends. What they are going to look at how we are supporting people and how people feel about our services and how confident we are around our market and our market position, which I think around the market position and sustainability, we are more confident now than we have been. But there has been times when markets do become quite volatile, and that's what they're looking at, how we would manage at those times. And then the finances, obviously, we've already made it quite known that per head per capita, we don't have enough money to support adult social care in the way we would want to. And equally, Peter has just highlighted again around the inequalities we face and the ageing population. But we would highlight that really quite clearly in our self-assessment to say, yes, we know ourselves well, and these are the areas where we've got gaps and concerns and what we're doing about them.
Great, thank you, Jamila. Gabby, did you need to come back on any more of that?
Yeah, just to echo what Jamila said, and in terms of your specific questions around Birmingham, so we haven't had feedback from the Birmingham pilot, only Nottingham and Lincolnshire so far, and they have assured us, and the CQC have provided assurance that they won't be speaking to finance colleagues or doing a deep dive into spending, just because it's got a political agenda to it.
Yeah, and the last bit about wellbeing, we are supporting our staff. So Gabby is doing workshops just to make the inspections not be a point of contention for people or point of stress. What we do say, we should never chase an inspection. We all should work in a way when an inspection should be a part of our day-to-day. So I think Gabby's working hard with staff to say, how can we continuously improve how we deliver services, working with Sean to say, what do people say about the service that they get? So when the inspection does come around, it's more business as usual rather than chasing an assessment and becoming quite stressed. It's easier said than done. I know from my children's days, but I think that's what we're trying to be well prepared as much as we can. Hence, we're rolling through the directory of evidence of over 80 documents now, rather than leaving it to sort of the end.
Great, thank you. Unless anyone else has got anything burning they want to ask about CQC inspections, I'm going to move on to the agenda item 8, the Healthwatch report. ADHD and the autism pilot pathway. Sian, can I ask you to speak briefly on the report?
Yes, thanks, Chair. I think I'll have to. And thanks also to our public participants and our partners in producing this report. This might be a weird way to introduce the report, but please bear with me. I was watching Frozen 2 a few days ago, which used to happen quite a lot, but thankfully we've moved into a Cars phase. And I was struck when Olaf reminds everyone that water has memory. And it made me think whether water has memory is debatable, but what is true is that systems don't, only people do. And in many ways, I'm disappointed to be bringing this report to you because the concerns laid out within it reflect something I view as an absolute, namely that our health and care system works best for people when you design it with them. One of the big selling points of integrated care systems is the idea of designing health and care with our communities, making sure we understand and respond to the needs of our local population. At its essence, this report is about that not happening. It's the failure to co-produce a solution to a problem with our population, a failure to properly engage our community. And that's when I have to remind myself that although this seems to me to be a self-evident truth and that it sits at the heart of integrated care, maybe our system doesn't yet have that shared memory. I could point to previous reports about closure of archways and how the hospital didn't realise how our population would view that, the closure of Bootham Park and the impact of people not being able to be fully involved in the decisions about health and care in the city. I have brought reports to this board before asking that we commit and recommit to the principles of co-production, of nothing about me without me, but people move on, structures change, and hard lessons learned can be forgotten. There it is, systems don't have memory, which means part of my job, and all of our jobs in many ways, is to continue to reassert the benefits, the need for co-production every single day. Because if we don't keep championing that approach, we will keep repeating the mistake of not engaging with our population before decisions are made. I want to acknowledge this personal frustration up front because I think it's vital to say I fully understand the pressures the health and social care system are under. I fully understand we do not have infinite resources. I understand the fear that without a change being made, that waiting list could just grow exponentially. It could be that providing more isn't an option. I know that the health and care system is being asked to bring in efficiency savings. The only way to invest in more ADHD and autism assessments may be a nationally funded commitment to do that, which I would welcome. I agree we need to consider how to target support to those who are in greatest need. I understand that peer support and training may be beneficial to all, though a diagnosis that provides a legal requirement for employers and education facilities to make adjustments is also needed. What this process did was put the health and care system in opposition to the people who are neurodivergent and believe themselves to be neurodivergent. And once that happens, we end up in an adversarial relationship where no one wins. There is so much potential for us to work well together to do better for all our population. There are amazing individuals in this city, both within the health and care system and some here today who are passionate about changing our approach and improving the lives of neurodivergent people in our city and beyond. Our vision as a health and care system is about early intervention and prevention. I hope that this is actually about the start of a shared learning journey rather than a fault line that we have to split down. So I ask the board to receive this report and to confirm where it is best considered to go forward.
Thank you, Sian. Councillor Runciman.
2 quick points, Chair, so I'm aware of the time. First of all, I don't want us to lose what one of our speakers talked about, which was learning from the dementia strategy implementation. And I think we can pick up a lot from that and add it to perhaps a revision of the autism strategy. And the second thing is that there has been work going on in the council about digital exclusion, and that comes over very powerfully in this report. It's an excellent report, and I thank Sian for it. But we can't expect everybody to self-diagnose on something which requires what they see as quite complex computer skills, and that really does need looking at. Thank you.
Thank you, Councillor. Sarah.
Thank you, Chair, and thank you, Sian. I'd like to take a few minutes, if we have that, Chair, if you'd afford me the opportunity just to give some words. I think first of all, just like to say, I think Sian has absolutely hit the nail on the head. And, you know, we've had these conversations, haven't we, you and I, in terms of the communication of the pathway, why the pathway was, or why the changes to the pathway were brought in, and the nature of that with the team, that absolutely could have been better. We will learn. You have that commitment from me that this will not be passed over, and we are indeed already learning in terms of that this is not how we want our patients, our public, our families, our advocacy groups to feel about the integrated care system or the York Place Health and Care colleagues and partners. So you have that commitment from me on behalf of York Place, but also on behalf of the Integrated Care Board. You have that on behalf of York and North Yorkshire leaders. In terms of us learning from this, I'd like to take just an opportunity just to share some specific thoughts as well in response to the recommendations, if I may. So I'm just going to talk through just very briefly, if we have time. So the referral criteria. So first of all, this is a pilot. It was brought in extremis. In the sense of a very large increase in demand. We've had a 20-fold increase in demand in 6 years, and then within a short period between the commission service, an increase in demand from 60 to 180 referrals per month on average. Now, the pilot was brought in, as I say, in those extreme situations to support the provider against the very real risk of losing the service entirely. So that was the situation. However, at that point, there was a path that could have been followed in terms of then co-designing and co-producing. Now, the time did not allow for that, perhaps, but still there were opportunities to communicate around the potential changes for the pathway that were those opportunities were missed. Now, further amendments have already been made, so the criteria have been expanded. The clear pathway to enable community healthcare teams to refer. I think we heard earlier from, just trying to see which one it was, but it was around the crisis plan and a reason for the crisis plan not being sufficiently a broad criteria to enable access. That has been amended. The criteria have been expanded. We will continue to do that. And as a board, we've given permission for the clinical, professional and lay engagement groups to be able to make those decisions without having to come back to board in terms of continuing to respond to the feedback and the engagement. In terms of committing to invest in meaningful engagement, my priority is to ensure that from now we undertake authentic, meaningful engagement with people affected, both in terms of their experience, perhaps of the diagnosis pathway already, and also people who are waiting for diagnosis, their carers and their advocacy groups. We are holding, I think next week, Sian, and we've invited both North Yorkshire Healthwatch and York Healthwatch to co-design the focus group engagement work that will take place over the autumn, starting no later than November, hopefully earlier if we can organise that. We would like to co-deliver that with Healthwatch as our local partner, if that's practical. In terms of the Do It Profiler pathway, the do it profiler pathway, I think, is a recognition of the fact that traditional service models do need to be broadened. We do need to look at alternatives, but they need to sit alongside a assessment pathway, a waiting list for assessment. And in the meantime, the option to access the do it profiler is there. We are continually trialling that pathway, gathering evidence, to understand how that might inform a longer term proposal. Is that a meaningful addition to a pathway that adds value for people who are waiting? I think it's worth noting that previously no support was offered during those long waits for assessment. So this is part of a package in terms of providing people with a validated tool to support in terms of accessing an ability to understand behaviours and feelings and have a validated tool to talk to employers and family members about. In terms of access, actually, as well, just to pick up, there are mental health primary care practitioners in GP practices available to support people who need that additional support in terms of accessing and filling in the Do It profiler as well. But again, we're learning through this as much as anybody else. We need to be co-designing, as you've said, and we heard earlier from, I think it was Hazel, that sense of being forced to engage in services that aren't designed for people. We need to get that right, and we will get that right this time. You have my assurances on that. In terms of the pathway, I just want to take the opportunity to absolutely confirm, because this was not clear. I think it was clear in the evaluation report that Healthwatch have presented today, that it wasn't clear that everybody who is going through the pathway will have the option to remain on a waiting list for assessment. The Do It profiler was introduced primarily to provide a way to assess people based on need, and to ensure that we did prioritise need and shifting focus from a diagnosis-led pathway, which saw people in chronological order, and moved to a needs-based pathway, which was able to triage risk. So everybody through that process and through that pathway will have access to Do It profiler. The most at risk will be prioritised for face-to-face assessment, but also everybody will have the opportunity, should they wish to consent, to remain on the waiting list as well. Just finally to mention as well that there has been a great deal of professional engagement, just to provide that assurance, accepting that the patient engagement was not where it needed to be. But in terms of internal, there has been multiple conversations through our system ethics panel around supporting that approach in terms of shifting focus from diagnosis-based to a needs-based pathway, making sure that the most disadvantaged, those most disadvantaged by the condition are prioritised for assessment and diagnosis. And we've had extensive debate through our public health, nursing, medical colleagues, chaired by an ethicist, as well as engagement with all of our clinical and professional leaders across Humber and North Yorkshire. I think what this has done is raise the profile, actually, of the need to recognise this as a national issue that is bearing out locally, and we will be embarking on a piece of work across Humber and North Yorkshire to recognise how do we actually tackle this together as a system. This issue isn't going to go away, and we do need to find ways to support people pre and post diagnosis that embraces both traditional but actually more innovative service models in future as well. So just wanted to take the opportunity to respond and thank Sian for the work that she's done, the report that's been done, and as I say, we are listening. Thank you.
Thank you, Sarah. I've got a couple of things I was going to say, but Councillor Webb.
Thank you, Chair, and thank you again to Healthwatch for bringing this. I think it's further evidence of the benefit of Healthwatch as to how we can, work together and make improvements where needs be, and how, there's that communication with the public. Thanks, Sarah, for everything you've highlighted there in your sort of feedback and going through those recommendations. From our point of view, I suppose, what's the time frame for improvement? How are we going to be kept aware of what changes you're making over time? And also, how are we going to be made aware in report of the barriers that you face? Because, resource is a real issue. We've all said that, and I think that that needs to be almost highlighted as to, you know, this is what we'd like to do, but actually this is what we can do. This is what we can afford to do as the NHS, for example, you know. And then, yeah, overall, what's the time frame for hearing back that there has been improvements made? You've talked a lot about co-production and a lot about what you want to do to make it better, but how long is it going to be before we hear from public participants that there is improvements?
Thanks. I'm just going to ask my couple of things before we just kind of do any final remarks that people want to make. The things that struck me from the report, and thank you, Sian, again, this is only my second meeting, but it has definitely been, it's become the theme that you are the light that shines on the particularly pertinent issues that are really kind of affecting the public. The thing that particularly struck me in the report was around the importance of honest and clear communication. And I don't think, you know, as Councillor Webb just said, I don't think anyone is under any illusion that there was a pot of money somewhere that could have been spent that wasn't. That isn't what this was about. But I do think if there is pressure on budgets, which we know that there is, that being honest about that and clear with people about what they can and can't expect, I think is really important in terms of ensuring that people don't lose trust. And I would pick up on the point, I think it was Hazel that said it in her contribution around the fact that it increases risk and the pressure on people if they don't get clear communication. And clearly, we should all be in the business of wanting to reduce the risks and the pressures that people are facing when they are, you know, undergoing and wanting to undergo a diagnosis for something that might have been, you know, bubbling around for a long time. So the communications question, I think, is really important. I also just wanted to ask about the kind of equalities considerations that were given at the time of the change, at the times of the introduction of the pilot. Partly because of the digital exclusion issues, and partly just because in any development of any pilot, you would expect the kind of equalities assessments to have at least been part of the consideration there. And again, it comes down to a communication question. If that was considered, what was the outcome of that, and how transparent can we be about what that was? I know that, you know, that there isn't, you know, that there are huge pressures on, there's increasing demand, there's huge pressure on budgets. We understand we have the same problems within the local authority. I think one of the messages I took from the report was that people just need to know where they are. And if there's a triaging process and it means that some people might have to wait for 5 years to get their diagnosis, at least if they know they're going to have to wait 5 years, and that they're, you know, that is what it is. Or if there's a review process that's possible if your circumstances change or your mental health deteriorates as a result of not having a diagnosis, what's the pathway that, you know, what's the reviewing process for that? But look, it is important that Healthwatch have shone the light. It's really welcome that you are looking at it and you've heard what's been raised. We will bring the recommendations of the report back to the next meeting, if that's appropriate in terms of an update, or certainly in the next couple of meetings, just to ensure that we are revisiting these recommendations, to ensure that, you know, we are monitoring it as a board. Does anyone else want to come in? Yes, Peter.
Just very quickly, I mean, it feels as if 20-fold increase in need for this service was something that the ICB as the commissioner obviously had a huge amount to try and tackle. But I don't think this is just about the ICB as a commissioner and the provider of the service. I think there's a broader point. I think that your report, Sian, makes it about our approach to autism and ADHD as a city, the fact we have a strategy which has lapsed. So I guess my challenge to us is, how do we all gather around the ICB and help support the ICB in its challenge here, because this is a huge challenge, but also obviously support our community in the city who are living either with a diagnosis or without that diagnosis, for a city who's changed its profile and attitude and sort of structure when it comes to supporting people with neurodivergence. So I think something about that autism strategy in general for the whole city should be incorporated into our sort of next steps.
Thank you. Sarah, do you want to?
Yeah, thank you very much. So just responding to those points. So the question around when will we see this improve? So in terms of the communication, I would hope that Sian will be able to give us an update at the next meeting around the sense of something shifting in terms of the approach to listening and being honest and transparent and open with potential users of the service through that process in terms of how can we make this experience better. So I hope that we will see that immediately over the next few months, if not earlier. Just to highlight as well, the commission service hasn't reduced, so that we have one of the positives here. And again, this is we've lost the ability to share some of the positives because of the nature of the way that this was communicated. But the commission service has been maintained in terms of the level that it was commissioned at. There hasn't been a reduction in service. And actually, one of the elements around risk was about mitigating the increasing risk of seeing people in chronological order and not having a way to be able to support people potentially in higher need. So the Do It profiler was part of that strategy in terms of implementation. But in terms of the analysis of that, the equality assessment is effectively being continually amended. So version 1 was opened at the commencement of the pilot and is continually being updated, and that can be shared in terms of where we are at with that. It sets out the clinical risk assessment as well as the digital elements that we've talked about here. Just want to refer as well to the sort of the expansion of the pilot and the pathway. We will commit to publishing that on our website. So what I'm keen to do is by the 1st of October that we have that on our website. We have already have a place for all pathways that is accessible openly, and GPs use that, and the public can access that as well. So I'd be keen that that's where we place this and promote that as well through all of our communication channels, that we write to every single patient who is currently on that waiting list to ensure that they can access that as well, so that the pathway is absolutely clear. I do welcome Peter's suggestion in terms of let's all wrap around this. Let's recognise the responsibility that we all have as health and care partners in terms of that wider autism strategy. I also just want to take the opportunity to come back to Gemma, who you're still in the room. That's fantastic. Just to highlight that, I will pick up on that particular point that you raised around. I suppose what I was hearing was diagnosis essentially being the only route to financial support. So I just want to let Gemma know that I will pick up on that specific point. So if we can, perhaps if you want to give your contact details to Reese as the Democratic Officer, then we can pick that up outside the meeting.
Brilliant. Thank you, Sarah. That's really helpful. And hopefully that has at least enabled us to have a kind of, it was clearly an issue that was pertinent in the, in the community, and it is really important that this board is able to pick up on that. And Healthwatch, thank you again for the work that you have put into this and the other reports that you produce. It's hugely appreciated. And, it's nice to think that sometimes, even though there are all these big challenges, that we can, try and improve things and try and, come together as a board and as a set of partners to try and improve the health and well-being of the city. Has anyone got any other business that they need to raise? I'm really sorry that we've both overrun and I didn't take a break. I'm gonna say it's because we started late, but it wasn't entirely that, because we didn't start at 1:45. Apologies. Thank you all for bearing with us. The notice of the next meeting will be published with papers 5 working days beforehand, so that we can make any decisions that we need to make. Yes. But thank you all for coming and for your time and contributions. It's really, I'm really grateful as a board, and we will continue our work to try and improve the health and well-being of the city. So thank you.
Thank you.